All right. Our next presenter is Dr. Paul Dangerfield from the George Washington University Hospital, who will present on implementing bedside regional anesthesia, improving clinical effectiveness. Dr. Dangerfield, welcome.
Thank you all for your time today. A little background, the acute pain service is made up of 5 physicians, 4 nurse practitioners, and 6 nurses that help to address complex acute pain related issues with patients, from scheduled surgical procedures and patients that have injuries and pain as a result of trauma. We're really trying to address 2 simultaneous crises. The first crisis that everyone's aware of and people talk about is the crisis of the opioid problem in the country, which has cost thousands of lives. The other crisis that doesn't get much attention is the poorly treated acute pain crisis, which I think leads to untold suffering and is also, because it hasn't been well managed, is a major contributor towards the opioid crisis. So we as a system have been putting in a lot of regional anesthesia, peripheral nerve blocks that numb up the affected part of the body, and as a result dramatically improve the patient's comfort and significantly decrease the amount of opioids that a patient needs, and we decrease the amount of physiologic problems related to poorly controlled pain. One of the problems that we faced is that historically the peripheral nerve blocks can only be placed in the perioperative setting, the operating room, pre-op, the recovery room, and the ICU. We had a lot of patients who needed nerve blocks, but we really didn't have a place to do them, a place to land. And as a result of that, patients waited hours, if not days, in order to get a nerve block. In trying to address that delay, which was dramatically affecting patient comfort and safety, we came up with the idea of a mobile block service. And with that, rather than being isolated or anchored to those normal places where peripheral nerve blocks are done, we talked to the hospital and we told them about our challenges in getting access to patients and access to a place to safely put the blocks, to develop a mobile block team. And we talked to the nursing administration, the C-suite, and pitched our idea, and they agreed on a pilot basis in January of 19 that we could go ahead and give it a try. We had all of the equipment in 2 backpacks. It was important to us that we were elevator independent. In a lot of hospitals, getting patients in and out of elevators, or even getting staff and equipment in and out of elevators, increases the time and the duration until a patient receives the appropriate care. So the picture that you can see now are one of our residents and our charge nurse that have all of the equipment that's necessary to place a peripheral nerve block. And they also have, just as importantly, all of the emergency equipment if there was to be some kind of problem related to placing the nerve block. So we initially talked about how do we get access to those patients. We have the residents that are on the service see the patients and determine whether or not it's appropriate to put a block in and get consent. Then we dispatch a team to the patient's bedside, do a safety timeout that's performed exactly the same way that we would do in the operating room. The block is performed. The team then monitors a patient for 30 minutes afterwards, and then typically we're off to our next bedside nerve block. Over 8 months, we looked at the difference between the blocks that were done in the usual PACU location and those mobile nerve blocks. We looked at the length of time that a patient would have to wait versus the conventional PACU sighted nerve procedure related to doing it on the mobile block team, and we recorded those times. We noticed that there was a dramatic decrease in the time that it would take from the realization that a patient needed a nerve block until the nerve block was completed. And so in that 1 year post implementation, we saw a tremendous decrease in the amount of time that it would take to do it. So this slide goes over our realizing that there was a problem, implementing our solution to it, and then continuing to follow up on whether or not there was an improvement in patient care and to make sure that there were no new problems that were created. So in having to wait for a patient to be brought downstairs, to take them to the elevator, wait for the elevator, bring them down, take them to the recovery room after a spot opened up, that we noticed that it was about triple the time to get a block done in the PACU versus the mobile team coming to the patient. And if you think about, if you had a loved one who had a broken arm, broken hip, something like that, that was in intense pain, waiting triple the time is something that no one would want a loved one to be a part of. And so we were able to dramatically increase the number of the non-perioperative blocks that we did and increase the total amount of blocks as a result of it for the patients that were in the hospital. During the initial phase 1 and phase 2, no adverse events were recorded. We're now a couple of years out, and we've gone from a relatively small number of blocks to now we've completed over 450 bedside related mobile block team blocks without any complications. And the growth and the acceptance within the institution continues to increase. So in conclusion, having a mobile block team that doesn't depend on fixed sites in the hospital to do these nerve blocks dramatically reduces the waiting time for the patients. This, as a result, reduces the amount of patients that the pain are in, significantly reduces the amount of narcotics needed to treat the pain. As a result of that decreased exposure, we're reducing the potential towards long-term opioid abuse potential. We feel that this is a relatively low-cost intervention that all hospitals could safely implement and improve the patient care. As an aside, we've talked about two crises initially, the untreated pain crisis, the opioid crisis. There's a significant body of evidence that's growing during the COVID crisis that by not having to intubate or instrument the airway in patients that need surgery and doing a peripheral nerve block, it makes it much safer for the team. And also not having to take a COVID positive patient from their room down the hallway, into an elevator, down another hallway to a place, significantly reduces the potential exposure to the hospital staff and other patients. And this may end up being another significant benefit of that mobile block team. Thank you all for your time.
Thank you. That's interesting. You mentioned this started before COVID, but may actually have ended up having some positive impact there. That's a really good point about not, having to take those patients out of their rooms and move them around. And creative, thought, why not bring this to the patient rather than the patient to it in order to reduce time? Really outside the box thinking. Given how you sort of described it, how important was it to get interdepartmental collaboration to the success of the project?
It was very important. And initially we needed buy-in from the nursing staff in the hospital. And because of the prior success of the acute pain service, that was not very hard to do on a trial basis. The system is set up where we have only staff that routinely put nerve blocks in can be a part of this. So it has to be one of the acute pain nurses and it has to be one of the acute pain physicians have to be present with every block every time so that we have people that are experts in the field and are comfortable doing it. And during the time, we've not changed that because it's working so well. Maybe over time, we'll do that. We see other teams will see the block team with their backpacks in the hallway and will actually stop us and say, we didn't even think about it, but we have a patient in another room that could use a block. Are you available? And so answering that question directly about other services, when people see the group with their backpacks on, it kind of prompts them to say, hey, what about our patient? And we pick up a fair amount of consults and blocks that way, where those other disciplines and other teams it might not occur to them to get that block in and then decrease the pain and then decrease the exposure to narcotics.
Yeah, and you mentioned narcotic use. Are you able to track any metrics post-discharge for follow-up with the patients?
We follow up with all the patients that we send home with a block on routinely, and we watch their narcotic usage. With a regional anesthesia, we know that there's a huge difference. Taking, say, shoulder replacement surgery, for instance, that historically patients might be in a hospital for 2 or 3 days on a PCA with around-the-clock narcotics. more and more in our hospital, we're sending patients home within a few hours of having their shoulders replaced with an interscalene nerve block placed on Tylenol only or very, very intermittent narcotics. So we know that there's a tremendous reduction in the amount of narcotics that patients need with regional anesthesia, whether it's with a mobile block team or placed in the typical setting. And that's why I think it's so important that all hospitals embrace regional anesthesia with catheters so that we can continue that pain control, reduce the negative physiologic effects of someone in pain, and dramatically reduce the amount of narcotics that they're exposed to. We know whether it's as little as 5 days makes an enormous difference. And that seems to be the first inflection point where you're putting one of those patients at risk for an opioid use disorder. And so by having people off narcotics within a day or two, we're dramatically changing the path of those patients, and we feel reducing the number of patients that might become dependent on narcotics later on. We're also seeing, just as importantly, that we're changing the prescription or prescribing patterns for the surgeons and the trauma services, where they're sending less prescriptions, less pills are prescribed to those patients. And we know historically that most of the prescriptions are not used by the patients, and those pills that are sitting around the house that are also not uncommonly diverted by friends and family or somebody else for inappropriate use that can lead to bad outcomes. So we're putting less pills on the street as the result of regional anesthesia and the mobile block service.
Great, great. I think we have time for one more question, and we'll see if this is a simpler one or not. Someone in the audience was saying, do you have any data for 2020 to show your continued use and success? I think the slide only showed 2019 data, unless I missed it.
We have a dramatic increase. We've gone, I think, from the initial study from just 40 or 50 blocks to now over 450, and it continues to increase exponentially. Our overall blocks that our acute pain service deals with over the last 10 years has increased about 22 to 23% a year. And with the mobile block team, our ability to get more blocks in a given day, we see those numbers climbing even higher. And so the success breeds success. And with this, we're actually looking within our institution on how to come up with additional services that can constantly go out to different parts of the hospital. We've gone down to the emergency room, to the floor, to the ICU, all over. And as the institution realizes that those services are there and it's in the front of their mind, our growth is exponential.